but nurses are there when our babies are born. You are there taking care of mothers who suddenly find themselves with a baby. You are there in the emergency rooms when we are injured. You are there when we are dealing with very serious illnesses. And you are there providing the humane and compassionate care that every human being needs at the end of their lives. You are there to be there. And all of that and much more is why nursing is the most trusted profession in America. That is why nurses are the backbone of our healthcare system, and why it is way past time for hospital executives to treat you with the respect and dignity. Divert too much from the purpose of the hearing today, but I don't have to tell anybody in this room, I think anybody in America, that we have a healthcare system, whether it's New Jersey, Vermont, or any place else in America, that is dysfunctional and is broken. I want to say a word on this because it ties into what we'll be discussing in a minute. I want everybody here to know that in the United States of America, we spend almost twice as much per capita as any other major country on earth. You all know that? We are spending $13,000 for every man, woman, and child in this country. We should have the best healthcare system in the world. But not only do we not have the best healthcare system in the world, we are behind many, many other countries. Despite our huge expenditure, 85 million Americans are uninsured or underinsured, and you deal with those folks every day. Unbelievable, and it is not talked about at all. Some 60,000 Americans die every single year because they don't get the medical help they need when they help them, right? You see, they're sick, and the doctor, nurses, why didn't you come in? Why didn't you come in 6 months ago when you had your symptoms? And the answer is, I was uninsured. I couldn't afford the deductible. The function of a humane and civilized healthcare system is to provide quality care to all, not to make huge profits for the insurance companies. Another issue that is not talked about is our life expectancy. How long we live is much lower than other countries and is actually in decline. And for working class people, lower income people, the gap in their life expectancy with the rich is about 10 years in America. That is unacceptable. And on top of all of that, our broken healthcare system is one in which we do not have enough doctors, we don't have enough dentists, we don't have enough mental health practitioners, we don't have enough pharmacists. And perhaps most disturbingly, we have a major and growing shortage of nurses. That, in my view, is because of two basic reasons. First, our nursing schools are unable to educate the large numbers of young people who want to become nurses because we're not investing in nurse educators. Young people understand how important And what a wonderful profession nursing is. They apply for nursing schools, they can't even get in because we don't pay the educators the kind of salaries they should be. And I should tell you that is an issue the committee that I chair is attempting to address. But the second reason, and what this hearing is about today, is that there are over 1 million Americans who are licensed to be nurses, but are no longer doing the jobs that they want to do and that they love because the working conditions in hospitals are often deplorable. And how sad it is, how tragic it is, that these nurses who want to do their jobs, compelled to do their jobs, no longer feel comfortable in doing that work. And that brings us to why we are here today in New Brunswick. For nearly 90 days, some 1,700 nurses at the Robert Wood Johnson University Hospital have been on strike. What is this strike about? Yes, nurses at Robert Wood Johnson and workers all over this country want better wages and better benefits, but that is not the primary reason for this strike. What the nurses have told me, and I've had the opportunity on several occasions to sit down and talk with these nurses, is that what this strike has everything to do with is the safety of their patients. Tears in their eyes, and I've been in the room, and I've seen the tears in their eyes. Nurses have told me that they are simply unable to provide the quality care they want to provide and the care their patients deserve. And the reason for that is the totally inadequate nurse-patient ratios that they are forced to do. Nurses in New Jersey, Vermont, and all over this country have told me is they have been stretched to the breaking point. They tell me that they are stressed out, they're burnt out, and are leaving the profession they love in droves because they are overworked, undervalued, and are forced each and every day to do more work with less resources. In a moment, we are going to be hearing from the nurses and experts on this panel about this crisis and what Congress can and should do about it. I also want everybody here to know that the committee did not just invite nurses and union representatives to this hearing. I very much wanted to hear both sides of the story. I think it's important to hear what the hospital has to say. We invited Mr. Mark Manigan, the president of RWJ Barnabas Health, which owns the hospital, and Alan Lee, the CEO of the Robert Wood Johnson University Hospital, to give us their views. We invited them. We have been discussing their coming here for many, many weeks. Unfortunately, while Robert Wood Johnson told the media that their executives would be attending this hearing and were eager to set the record straight, that's what they told the New Jersey media. They have both declined. They have both declined to be here today. So let me, in their absence, tell them what I would have asked them, some of the questions I would have asked them if they were here. I would have asked them why they have some 1,700 nurses out on strike for nearly 90 days to improve safety at a hospital system that made over $4 billion in revenue in the first 6 months of this year. would have asked them how their healthcare system could afford to spend over $100 million on traveling nurses since the strike began. But somehow cannot afford to mandate safe staffing ratios to improve the lives of patients and nurses at the hospital. I was also very curious to know how this nonprofit hospital could provide some $17 million in CEO compensation for one person in 2021. Those were a few of the questions we had in mind. Let's be clear, what the nurses at Robert Wood Johnson are asking for, and it's important to make this clear, is not a radical idea.
Not at all.
All they are asking for is for this very large nonprofit hospital chain to mandate the same nurse-patient ratios that the state of California mandated some 20 years ago. And nurses in New York City won as a result of a strike some 10 months ago. Research, and we're going to hear more about this from people who know more than I do, but the research on this issue is clear. After California mandated adequate staffing ratios at hospitals, patient safety went up, unnecessary deaths went down, the retention of nurses went up, and medical errors went down. In other words, the safe staffing law in California has not only saved lives, it has saved hospitals money. When hospitals are adequately staffed, they are safer, they are more effective, and they are more cost efficient. As chairman of the committee, I am working hard in a bipartisan way to increase the number of nurses in this country and to retain the nursing workforce that we have. But at the end of the day, the people who are going to bring about the change are the people in the system themselves. For better or worse, nurses are much more respected than politicians. The driving force behind change. And I just want to conclude by simply saying, you know, it is rather extraordinary. I know going out on strike is not something that you do every day, you've never done in your lives. And the idea that you're willing to go without paychecks, to walk on picket lines, to deal with all of the stuff out there, in order to protect your patients is rather extraordinary. So on behalf of the American people, panelist that we're going to hear from is Judy Danella. Judy has, as I understand it, worked at Robert Wood Johnson for 28 years. And is president of the United Steelworkers Local 4200. Judy, the mic is yours.
Thank you, Chairman Sanders. Good morning, Chairman Sanders and everybody participating here. Thank you for the opportunity to speak on this important issue of safe staffing. Again, my name is Judy Danella. I am first and foremost a staff nurse on 7 Tower in Robert Wood Johnson and president of Local 4-200, which represents 1,700 nurses at the Robert Wood Johnson facility in New Brunswick. As many people have noted, we are in the midst of a genuine crisis in the nursing profession. An estimate from the National Council of State Boards of Nurses suggests that roughly 100,000 nurses have left the profession since 2020. And New Jersey is estimated to be one of the top 3 states that will be understaffed in this nation. Worse yet, the crisis was not limited to the COVID-19 pandemic. Rather, we are in dire straits. That same study also found that about 20% of current nurses were considering quitting their jobs. As frontline caregivers and nurses, we know that safe staffing is crucial to the health and well-being of our patients and our ability to provide quality, safe patient care. It is crucial to our patient satisfaction rates, nursing retention, safety, and the future of nursing. One of the main reasons we find ourselves in this situation is because of the chronic understaffing by hospitals, which has made the nursing profession increasingly unsafe, both for nurses and for patients. This dynamic creates a vicious cycle. Hospitals understaff their floors, which puts nurses in difficult, if not outright impossible situations, which can leave them spread too thin or at risk of getting hurt on the job, causing many nurses to quit, which only exacerbates our understaffing issues. In addition to making it more difficult to retain our existing workforce, this vicious cycle makes it harder to recruit new nurses. I have seen firsthand how the hospital prefers to hire younger nurses, often cheaper nurses, to replace the experienced nurses who have quit because of burnout and injury. The result have been to bring new nurses directly out of college with no prior clinical experience and put them directly on the hospital floor with 5 to 6 patients. Being a nurse is not an easy job. It requires a significant amount of training, both for technical and emotional skills for the job. By throwing younger, inexperienced nurses straight into the deep end and providing them with minimal training and patients to cover, the hospital is setting them up for failure, only exacerbating the retention problem we face. According to the American Nurses Association, nearly 1 of 5 nurses, newly licensed nurses, quits within the first year, often citing stressful working conditions, lack of leadership and supervision, and understaffing the facilities they leave. And let's be real clear, this issue of chronic understaffing is not the result of larger labor market forces, but it is a purposeful business decision by the hospitals. This job is a vocation for us. We do this job because we love it and we love our patients and our profession. The hospital knows we as nurses will do whatever it takes to provide the type of care our patients need, and that the dedication that we have, and they use that dedication against us. Nurses go into the job for the patients, not for the money. We love our patients. We are there to serve our patients and take care of our patients and the families. 85 days ago, over 1,700 nurses said enough is enough. We made the painful decision to go out on an unfair labor practice strike for safe staffing. We are no longer willing to be compliant to a broken system where management puts profits over patients. These so-called enough money to invest in their workforce to ensure that we have safe staffing. Instead, again, they line their pockets with the excess profits that come from chronic understaffing. According to an analysis conducted by the Senate Health Committee earlier this month, Robert Wood Johnson Barnabas paid their CEO more than $17 million compensation in 2021. And Barnabas itself has already paid over $102 million on replacement nurses, paying them well in excess of what we earn on our job and giving them better staffing ratios than we even ask for today. Is there to hire nurses as well as investments that would work the hospital a safer workplace, which would address the long-term recruitment and retention issues. In closing, I want to emphasize this point. Safe staffing is not just some abstract concept. It literally improves patient care, keeps more nurses in the profession, and most importantly, saves lives. I want to thank you, Chairman Sanders, for your leadership in bringing this to the front and foremost attention. I appreciate the opportunity to speak at today's hearing, and I look forward to answering any questions you may have. Thank you very much.
Carol Tany. Nancy is a pediatric recovery room nurse at Robert Wood Johnson and a member of United Steelworkers Local 4200. Ms. Tansey.
Good morning, Chairman Sanders. My name is Carol Tany, and I want to thank you for holding this hearing. I'm a nurse at Robert Wood Johnson, and I've been there for 25 years, all of which have been understaffed. As Judy mentioned, it's not an easy job or very glamorous, it's a calling. It's important because I know these children and their families want to get back to living their lives, celebrating birthdays, and playing with friends. My job is challenging, but I accept that and give my heart and soul every day. Being a nurse, there are moral, ethical, and legal obligations. I am bound by my New Jersey state license to uphold the highest standard of care for these human beings that are placed in my care. I'm legally obligated to question anything that doesn't align with that very high standard, and furthermore, to stop anything that could potentially harm my patient, which includes standing up to physicians and executive leadership, both considered positions of power. Patients don't come to the hospital unless they're very sick and very vulnerable. Being a level 1 trauma center, one of 3 in New Jersey, these children are often the sickest of the sick, suffering from highly complex health conditions, and all of that complexity can be very scary and confusing for patients and families. The only way to administer excellent care is by building a relationship forged in trust. I must make a connection with each patient and family to get them to trust that I will give the best care. Until that trust is established, I'm a stranger. Every patient deserves and expects my full energy and attention. At that moment, their child is the most important thing in the world. My ability to devote the required time to each patient allows them to relax and know they're my priority. It also helps me to properly assess the child. We had a child who was in the maintenance phase of chemotherapy. He suffered with the same childhood cancer that his father survived. The anxiety that his family had over the child's condition was amplified times a million. The child was going for an MRI to monitor disease progression. While I was prepping him, his parents mentioned he had vomited twice. Not normal, but they assumed it was because of a long car ride and not eating or drinking. He was never very interactive with the staff because he was traumatized from so many hospital experiences. This morning, he was just quiet for them. I asked a few more questions, last food or drink, not sure, any recent sick contacts. Well, he was at Grandma's house the day before until 8:30, fell asleep in the car, so they just put him to bed. Despite sleeping 9.5 hours, he was still quiet. I called the doctor to get an order for a blood sugar check and start an IV. This takes time. The blood sugar was 39, dangerously low. After calling doctor back with results, starting an IV and giving him a sugar solution, he started to behave more like himself. But during this time, my full energy and attention had to be here, explaining each step and answering questions. With an already skeleton crew, my other 2 patients were not ready to go for their procedures. I was now under attack by the operating room manager and surgical team because of the delay. It's a horrible ripple effect, and it is the status quo. The pressure to be everywhere at once while keeping everyone safe is enormous. This is physically and emotionally exhausting. I can't say no to any of these responsibilities, so I literally run ragged daily, still feeling like I haven't done enough. Nurses never turn their back on their patients, never. This is our community, and we carry a huge amount of trauma and guilt because of it. All nurses know that the people making decisions are not the people providing care. They are often not even healthcare professionals. If these execs have a loved one in the hospital, they will have a dedicated nurse, or what is called a 1-to-1 ratio. While the hospital is pushing a narrative of the importance of family and community, their actions clearly say otherwise. Nurses are not about propaganda. Looking good on paper is not the goal. Delivering quality care is. Education is an extremely vital part of my job. I must be able to give the parents all of the information they need to be confidently taking care of their recovering child. Again, this takes time and should not be rushed or interrupted. When you are short-staffed, something is likely to be missed. If you are interrupted and can't get back quickly, stress levels rise. In the hospital environment, everything is good until it isn't. Every nurse has many stories, and they stay with us, our personal traumas. We know it can be better if we had more staff. It's common sense. It's not having enough nurses, nursing assistants, unit secretaries, environmental staff, transporters, patient monitors, and equipment is a recipe for disaster. And the consequences are being paid in human terms. This is an unfair labor practice strike. It is about dignity and respect. Where am I? For patients and workers, it is about the fundamental right to quality health care for everyone. We walked out in the ultimate demonstration of patient advocacy. We are sacrificing a salary because we could no longer be complicit with the Robert Wood Johnson toxic culture of understanding. We know our patients deserve better, and so do we. The COVID healthcare heroes have been cast to the street. We no longer accept the weight of the guilt that comes with unsafe staffing. It is morally and ethically wrong, and we want to get back to the bedside, but refuse to return with the status quo. Spending $100 million on replacement workers is not the answer. These scams are money-driven, just by the nature of what they do. We are invested in seeing this hospital be the best in the state. That's why we fight. It's mind-boggling anyone could not want safe staffing, especially since money is no issue for this hospital. We demand robust and enforceable staffing provisions. We need strong recruitment and retention to be a priority, not leaving the nurses outside for 85 days and removing our healthcare benefits. We need real accountability by the hospital so that this healthcare crisis can be corrected. This hearing is so important. It is so overdue for us to have a serious national conversation about safe staffing in our largely failing healthcare system. Thank you, Chairman Sanders, for calling this hearing and giving me a chance to
Next witness is Nancy Hagans, President of the National Nurses United and President of the New York State Nurses Association.
Good morning, and thank you for giving me the opportunity to testify here today.
Bring the mic a little bit closer if you could.
Okay. Good morning, and thank you for giving me the opportunity to testify here today. My name is Nancy Hagans, and I'm the president of the New York State Nurses Association and the National Nurses United, the largest union and professional association of registered nurses in the country. The nursing workforce is in crisis. An increasing number of nurses don't work in hospitals anymore because our employers have made this job unsafe for our patients and for us. We are exhausted. We are overwhelmed. We are suffering moral distress. The leading cause of this crisis is the hospital industry refuses to hire enough nurses to staff our units safely. President of NNU, I'm constantly hearing from nurses who are severely short-staffed. I know firsthand. I work on a surgical floor where our staffing ratio was 1 nurse to 18 patients. It was insane. That's more than 4 times what is scientifically safe. When nurses are understaffed, we don't have time to give our patients the care they need and the way they need it. As a result, our patients are at higher risk of preventable medical errors, avoidable complications, and even death. I've been in a situation where I know if I had fewer patients, I might have been able to save a patient's life. It is the worst feeling you can imagine. Those experiences lead to moral distress. Hospital will claim there is a nursing shortage. There aren't enough nurses to hire to provide safe staffing levels. That's a lie. There are approximately 1.2 million licensed registered nurses who are not employed in 2022. Here in New Jersey, there are over 56,000 active licensed registered nurses who are not employed as RN. There is no nursing shortage. There is a staffing crisis. Then we must increase nurse retention. To do that, the government must mandate minimum nurse-to-patient ratio. California has proven that ratios work. Since 2004, the ratios law in California has improved patient care and increased nurse retention. A 2010 study found that if California's ratio and medical surgical units were implemented in New Jersey, they would have saved 13.9% fewer deaths in the state. Ratios would close them and are impossible to meet, but California hospitals all came into compliance within 2 years. Despite all the evidence that shows that success of ratios, most employers will refuse to staff safely, which is why we are organizing to win staffing ratios. This past January, after extensive negotiation at the bargaining table about staffing ratios, nearly 7,000 nurses in New York City went on strike. Contracts that include enforceable nurse-to-patient ratios. Nurses here in New Jersey and many other states are taking similar actions, but we should not have to strike to win common sense solutions. It is the responsibility of the government to enact the policies that will protect us on behalf of the 225,000 nurses represented by NMU. I strongly urge this committee to pass the Act 1113, the Nurse Staffing Standard for Hospital Patient Safety and Quality of Care Act, sponsored by Senator Sherrod Brown. This bill will establish mandatory minimum nurse-to-patient ratios modeled after the successful ratios in California. Every nurse and every patient across this country deserve the protection that staffing ratios provide. And improve patient care in our nation's hospital, nurse staffing ratios must be implemented. Thank you.
President of the Health Professionals and Allied Employees Union.
Thank you, Chairman Sanders, for organizing this crucial hearing. I'm Debbie White. I've been a nurse for 35 years. I'm also president of HPAE, the largest healthcare union in the state of New Jersey. We represent 14,000 healthcare professionals across the state. First, I want to say, steelworkers, you are my heroes! I'm also an AFT vice president, and Randy says hi, Chairman. And greetings on behalf of AFT's 200,000 healthcare professionals. My colleagues here mirror the experiences of our HPAE members. I've also talked in detail to my colleagues across the country, have heard the same exact stories in Alaska, Oregon, Montana, Ohio, Connecticut, Pennsylvania, and many others where we're represented. Hospitals are in crisis. Why? Because nurses aren't going to stay at the bedside. We have 140,000 licenses, nursing licenses in the state, and only a small percentage, 70,000, are willing to work in the hospitals. Not simply because of the pandemic, and we all know the pandemic was horrific, but it's the straw that broke the camel's back. But it goes much further back than this. It goes back to the corporatization of healthcare. Whether for-profit or non-profit, healthcare has become big business. What's the goal of big business? Make money. We make money off your sickness in this country. In New Jersey, most of our hospitals have made tremendous profits, even during the pandemic. One would think then the primary focus for spending those profits would be on staffing. Instead, and this has gone on for decades, nursing care, in fact, all hospital health care, is a line item budget cut to its lowest number in order to maximize profits to spend elsewhere. Hospital management and corporations that run hospitals are too often focused on adding a new fountain and lobby and other aesthetics, or paying for glossy advertisements and million-dollar Super Bowl ads, rather than building up staff. And have I mentioned they are also spending a lot on anti-union firms? Efforts against safe staffing laws and replacement costs during strikes. And by the way, this employer should be embarrassed to tell the public what they've spent on replacement costs. They should be ashamed. Last year, HPAE contracted with Change Research to survey nurses in the state of New Jersey who work in hospitals, and here's what we found. 30% of the nurses that we surveyed are no longer they've left hospitals, they're no longer hospital nurses. Of the 70% that remain, 72% have recently considered leaving. Most troubling is this. Of those with 0 to 5 years experience, 95 say they're likely to leave soon. The number one reason? Poor staffing. The second is burnout, related to poor staffing. We can't retain nurses in hospitals because of understaffing. Yes, we need to recruit nurses into the profession. Of course we do, and we need to recruit educators as well, but without addressing retention, that is, stopping the migration out of hospitals, it's as if we're trying to fill a bucket full of holes with water. Those holes are the working conditions of our nurses. So we are laser focused on staffing, on this staffing crisis and the solution. The AFT staffing campaign is called Code Red and has resulted in safe staffing laws in Oregon and Connecticut, among other states. The Pennsylvania bill for safe staffing is likely to pass in the second house. All of these bills will result in enforceable staffing ratios for nurses. Make no mistake about it. By now, we've all heard the slogan, safe staffing saves lives. It's truth though. We have 20 years worth of data since California adopted safe staffing legislation. The data's clear. The staffing law in California did decrease patient deaths, did decrease negative outcomes for patients like hospital-acquired infections, bed sores, and med errors. It did decrease injuries both for patients and nurses. and it did increase retention of nurses at the bedside. All of this saved hospitals millions. So safe staffing saves money. We've seen that hospitals will not be good actors. They will never, as you can see by my colleagues here who are missing, never agree to safe staffing on their own. It's why we need legislation. We need laws to force hospitals to staff safely. We have our own bill here in New Jersey, supported by steelworkers and all other unions in the state of New Jersey. It's S304 and A4536. By the success of other states. We are encouraged by the attendance in this room. Chairman, with your help, we'll be able to say first California, then Oregon, now New Jersey. Thank you.
Ms. White. Our final witness is Dr. Patricia Pitman, Fitzhugh Mullen Professor of Health Workforce Equity and Director of the Mullen Institute for Health Workforce Equity at George Washington University. Dr. Pitman, thank
you. Thank you, Chairman Sanders. In addition to directing the Mullen Institute for Health Workforce Equity at George Washington University, I also lead one of the 9 HRSA-supported health workforce research centers, and some of the research I will discuss was funded through this mechanism. Views expressed today, however, are entirely my own. As other witnesses have indicated, there's growing recognition that the nursing crisis has been largely caused by attrition. Surveys and our own qualitative research identify the main reasons for these departures as understaffing, poor working conditions, and the corresponding fear of harming patients. The experience of fearing and of witnessing this harm is resulting in moral injury, a form of trauma caused by not being able to provide the care they believe patients need and feeling that they are powerless to make change. Among the outcomes of this distress are depression and suicide. Nurses commit suicide at twice the rate of the general population. Nurses' concerns about staffing have been borne out in over 20 years of research. Outcomes shown to be associated with low staffing levels include patient mortality, failure to rescue, hospital-acquired pneumonia, respiratory failure, ulcers, falls, urinary tract infections, and patient satisfaction. Our team has also showed that nursing-assisted personnel staffing levels impact outcomes, specifically patient satisfaction. This is in part because without sufficient support, nurses' workloads increase. In other studies, we're looking at the effect on outcomes of overtime hours and agency nurse hours as compared to regular staff nursing hours. We find that these two management strategies for handling shortages do improve outcomes, specifically in this case, preventing pressure ulcers, up to a point. But beyond that point, they get worse. Over the past 5 years, we find overtime hours were 178% above the estimated safe threshold in our sample. For agency hours, the mean was 211% beyond the threshold, corresponding to a 3.5 increase in pressure ulcers attributable to excess reliance on agency nurses. This study can't tell us why this occurs, but we know from qualitative interviews that we've conducted that travel nurses feel less empowered to speak up than regular staff when they experience unsafe staffing or dangerous assignments. So why aren't hospitals hiring more regular nurses to stabilize the workforce? One might assume that hospitals with more resources would use some of that money to attract more nurses to regular positions, perhaps by paying them more. Indeed, that was likely the assumption that policymakers made during the pandemic when they allocated provider relief funds to help hospitals make up for revenue losses and address the staffing crisis. Our research suggests this is not the case. In the year prior to the COVID pandemic, we found no relationship between hospital finance levels and staffing levels, either positive or negative. We then looked at the 4 waves of COVID, and we found that in wave 2 and 3, there was actually an inverse relationship. This means that not only are hospitals that are traditionally better resourced not using those funds for increased staffing, but additionally, hospitals that had higher influx of cash during the pandemic had lower staffing. Our findings support the idea that something is amiss in the current hospital payment system. So how do we fix this? Research shows that mandatory thresholds will help ensure minimum levels. We find that among the 3 state strategies used, mandating nurse-to-patient ratios, requiring that staffing committees include bedside nurses, and requiring public reporting of staffing levels, only the minimum ratio law was associated with increased staffing. The other 2 had no effect. The other approach is to enhance incentives for hospitals to hire more nurses. So far, neither the hospital value-based program or the hospital acquired conditions program, which include nurse-sensitive patient safety measures, have been enough to offset the urge to cut costs by constraining staffing. But they could be reformed and combined with a mandatory approach. One idea is to include both nurse staffing hours per patient day and nurse turnover rates in hospital compare. This could subsequently lead to the inclusion of these measures in the hospital value-based payment program. Long-term, the way we pay hospitals for nurses and support staff may need to change. Rather than hiding labor in room and board, experts have been interested in exploring whether the actual nurses' hours per patient day could be an explicit component of the DRGs without driving prices up. In closing, while other elements of the nurse practice environments also matter, fixing unsafe staffing in U.S. hospitals is an essential first step, one that would not only improve patient outcomes, but would contribute to the health and the retention of hundreds of thousands of nurses. Thank you.
Let me begin the questioning with Ms. Danella. What I would appreciate is if you could put into human terms the fact that you've been a nurse for 28 years and you've seen a lot. What are you and your fellow nurses experiencing because of the kind of inadequate nurse-patient ratios that we have in terms of what it does to nurses and what it does to your patients? And talk about the emotional. We heard some discussion about what it means emotionally to see things happen that you feel badly about. So from a human point of view, as a nurse for 28 years, chat about that for a moment, please.
Tell Judy.
I think what we look at is, number one, our colleagues as support. When you go in and you look at the board and you see your patient assignment, and it says you have 6 patients under your name or 4 patients that are heavy patients, you look and you say, oh my God, what is my day going to be like? Am I going to be able to give that patient the care they need? I personally work on a stroke floor. Many of our patients are unable to get out of bed, unable to speak, unable to feed themselves. They are full care patients. You say, what is my priority that day? Do I feed the patient with the PEG tube that cannot feed themselves? Do I feed the patient that has flaccid on one arm and cannot feed themselves? So you look and you say, then do I have enough staff that's going to help me turn and reposition that patient as an RTEX? No, wait, I have to go answer the phone because there's no uniclerk. So where does my priority lie? That's what we have to look at. And the priority is not answering that phone, it's taking care of that patient that's at the bed, so that they don't get into queue, they don't get respiratory because we haven't been able to turn and reposition them, that they lay with a pressure ulcer because we haven't been able to change them. So you look and you say, let me make my day. I can do it, and it's a struggle for me as a 28-year nurse. Imagine the new people that are coming in, and we're saying, go, because I want to help them, but sometimes I can't, because I might have a cluster, but I gotta go off the floor, because my patient needs a stat CAT scan, and there's nobody to watch my other patients. So that's why I think safe staffing is bringing more to the forefront. We work in a level 1 comprehensive stroke center, comprehensive cancer center. We work in, no offense to the other unions in the hospital or other staff, we work in one of the highest acuity populations in the hospital. We deserve staffing, we deserve nurse ratios, we deserve ancillary staff, we deserve what we're asking for. It is not money, it is staffing.
Take that question down the line. Ms. Tansey, did you want to respond on a human level? What does lack of adequate staffing mean to nurses personally, the quality care you want to provide, and how you feel about not being able, in some cases, to provide that care? Ms. Tansey?
I think the word that comes to mind for me, just as you were speaking, is anguish. Like, you always have that feeling. It starts the night before your shift, where you're just wondering what you're going to walk into. And if you're lucky enough to have a full set of nurses, your unit clerk and your nursing assistant may have called out or been pulled to another floor that needs them more. You know, you're in a one patient's area taking care of somebody, but somebody else is calling out for you. It's the juggling, the constant juggling. Then you need a supply, and you go to the storeroom, and they don't have your supply. Now you have to call somebody. This is all time-consuming stuff that you can't pawn off on somebody else. So the anguish you feel, the dread, the anxiety that this causes every single day. You can't turn left without having something you need to do. Can't turn right without it. And there's no one to help. You ask your directors for help. I'm sorry, there's nobody to send you, as in an extra pair of hands. You can't ask your director because they're never on the floor. They're always at some type of very important meeting. There's never a person you can actually turn to for real help. So we try to support each other. We can't even go home and talk to our families because they don't even understand what we're talking about. This is very, very specific. This kind of trauma is specific to us because we know what we suffer. And to this point, nurses have been afraid to talk about this to the general public because we don't want to alarm anybody that it's scary in the hospital. We don't want to raise fears to people that they might not be taken care of properly. But have somebody's mother get a bed sore, and it's a nurse's fault. Have somebody have a heart attack, or like Judy's talking about, somebody who can't feed themselves. You have to take your time. If they've had a stroke, you have to be careful. You have to take your time. You don't want to rush them. They deserve to get their whole meal. But instead, you feel like you're shoving food in. And when you change somebody in the bed, you need 2 people. There's often not 2 people. So you're doing it yourself, rushing on one side of the bed, running to the other side of the bed, having the patient try to hold themselves over on the bed so you can do their back. Things that need to be done are not getting done. And we have not agreed to that. That's not what we signed up for. Try telling a new nurse. Hey, here's this great profession. Get a lot of debt when you go to college, then go someplace and work your ass off and not be appreciated. In fact, you can actually be abused. How are we selling this? How are we potentiating more people coming into the field? With this culture, I can't imagine.
Hagans, this obviously is a national issue. It is not a New Jersey or Vermont issue. You've been a nurse for many years. Why don't you give us your experience as well?
Well, first, we all know more nurses means better patient care, okay? As a nurse, you're walking into that hospital from 6:45. If you didn't have a cup of coffee, that was your first and last meal for the day. You're coming in to take a report. then you have to see your patients. I go in there knowing that I should be spending at least 5 minutes with the patient, but all I'm doing is giving them the medication and run again. And we all need to know, every patient deserves that human touch, where we have a conversation. Newly diagnosed, you walk in there, but you're being called in 50 million directions. Then now you start doing the blood pressure, you have to give the medication. It's 9 o'clock. And then now you're being called to come into round, because the doctors are saying, well, you're going to round, but you're in the room with the patient. Then it's already 11 o'clock, 12 o'clock. It's time to give your 2 o'clock medication and 12 o'clock medication. You are yet, as a nurse, to sit there and take a break. We're talking about quality of care. How do you expect me to deliver safe, patient quality care when I don't even have a minute to run to the bathroom? Your 2 o'clock medication. Then we continuously, that is the reason we need safe staffing ratios in the country. Imagine in New York, we have the law, but the state have failed us. They have not acknowledged and helped us. The only reason we have staffing ratios is to a contractual agreement. What about the other hospitals where they have no staffing, no union to fight? What about those hospitals? 75% of nurses are not unionized in this country. So let's do that math. How do we care for our patients? How do we expect to deliver quality care to our patients when we don't have enough nurse patients to care for those patients? That is the reason we are here asking that we need to have the minimum state staffing ratios in the country, across the state.
Ms. White, you have been a nurse for many years as well.
Yes,
Why
I
don't
have.
you jump in on that discussion?
35 years.
You get that mic closer to you and tell us what
I've been a nurse, a med-surg nurse, for 35 years. Who stays in med-surg for 35 years? As such, I saw a lot of new nurses. And I was pretty much the mentor and the mama to everybody on the unit, as well as the union president in my local. But I have to say this, what does it look like in human terms? My patients would say to me, I hate to bother you. I see you running up and down the hallway. Can I just ask you for one thing? And they try to be patient, but I mean, how long can you be patient when a nurse says, I'll be right back? And by the way, don't we all say that? I'll be right back. How many hours later do we get back there? Because something else hijacks our time. Simple needs go unmet. Simple toileting needs. Care, self-care needs. Patients don't get it. They don't get their meds in time. They don't get their dressing changes in time. They don't get their teaching. I mean, how many times have I thought, I'm going to teach this patient? I said to myself, that's a new diabetic. They have to know about diabetes. They have to understand what it's like to inject insulin. And I couldn't. I just didn't have the time because my time ran out. But the worst part about this is watching the new nurses that I've precepted and mentored start practice, and every hour or so have to duck into the bathroom to cry. Because they never expected to be so overwhelmed in school. But this is the reality of our work. Unless hospitals are forced to staff. Now, they'll tell you they know what's appropriate to staff. They will. But they don't want to ask their staff, what do you think is appropriate? Because we can tell you. And the science shows that there is a certain nurse-to-patient ratio that is safe. So with these new nurses, we'll retain them. We will keep them at the bedside. They won't be in the bathrooms crying. They'll have mentors because the senior nurses who have the experience won't have exited the profession. That's another problem. And honestly, The doctor walks in for 5 minutes, spouts some jargon, and leaves. And the patients look at the nurse and says, I'm not sure what he just said, can you explain it? And what do we say? I'll be right back.
Dr. Pitman, you've done studies on these issues. What does lack of adequate staffing ratios mean to the health of the nurses, the well-being of nurses?
Well, I think in qualitative terms, we've been hearing it, obviously, but we do know that it is directly linked to depression. Depression is directly linked to suicide. As I said before, nurses commit suicide at twice the rate of the general population. It leads to attrition, not just from the hospital job and churn, and we know that costs hospitals, I think this year they're saying $52,000 per turnover of nurses. So it's tremendous impact on the hospital itself. And as these things happen, even for those nurses who remain, unfortunately, you know, when you experience moral injury or burnout, for those who remain, it becomes deactivating. You lose your compassion, you lose your ability to have hope for change, and that has a direct effect on patients who are looking to nurses as their sole source of care in hospitals. So, and that's why we're seeing, I think that the figures are actually way higher than 1 in 5 nurses leaving. In hospitals, where most of the problem is, we're seeing 40% of nurses leave in their first year. And by the second year, 60% of nurses have left. It's a huge waste of human capital. And it's a tragedy for patients who are receiving services.
You know, it's a funny thing. If we were in some poor country, didn't have any money for healthcare, we might understand inadequate staffing. We're spending twice as much per capita on healthcare as any other nation on earth. I want to ask the panelists, what is your reaction, your emotional reaction, if you like, to a hospital that apparently has $100 million available for traveling nurses who are paid significantly higher wages than you are, who have nurse-patient ratios that are better than what you're asking for, I gather, and a hospital chain that can provide its CEO with $17 million in compensation? What does that do to nurse morale when you hear those things? Ms. Danella, you want to start that off?
I believe as nurses of an institution, many of us feel demoralized, as Carol had said. There was no respect for us as nurses for what they've done for us for 85 days. They could have taken that money. They are afraid if we win safe staffing, they would have to set the standard for all their other sites. We have taken that challenge on. We know that. Instead of saying we care about our nurses, they chose to make the travel nurses their priority, which is not right, as well as break our union. I believe in the end, that is the goal. They are willing to pay much money rather than respect our union, and all we're asking for, again, is a deal on safe staffing. I would ask them to come back to the table. If they called me right now, we would go back to the table, make a proposal, answer our proposal, and get us back to work. I think that's what we want. And again, this is a fight that we have taken on. We will continue, and we need safe staffing, and the executives need to look at us as human beings and as the employees that built that hospital the way it is. It wasn't the problem. We did it, and we deserve to go back in there with a fair contract.
Jump in on that, Ms. Tansey. What's the nurse's reaction? Apparently there is enough money available easily. $100 million. What do you think?
Well, disgusting comes to mind. enraged comes to mind. The narrative at the very beginning, every time we would bring up something as, you are the highest paid nurses in New Jersey. Not true. Not even true. And they wanted to shame us and make us feel embarrassed, that, like, as if we were asking for more money. That was never the case. They are so terrified of us being organized that they literally were taking pages out of Union Busting 101 and trying it. With the intimidation, with the fear, with the harassment. That is the culture at Robert Wood Johnson. They're doing it to the people who are in there now. Our environmental service people, our technicians, saying that if you support these nurses, you will be fired. And that's a threat they make good on. That's a threat they make good on. Our siblings at Claramas trying to get a contract. Every hospital to be unionized. Somerset is getting ready to be next. Threatening them over there. Threatening them that if they participate with us, if they communicate with us, that they will be penalized. That's a terrible way to go about business. That is saying you do not care about these people as people. You just want, shut up and go back to work. That's the attitude they have with us. Shut up and go back to work. And that's not what we're doing. We're going to stand up and fight for what this is. We're not losing steam, because this is too important. We didn't come out here to go back to a terrible contract. So if they come back with some stuff that isn't a good contract, it's going to get voted down again.
Is putting profit over patients. And the reason they're doing it is union busting. Management do not want the unions there, because if they have enough money to have replacement workers, this is not about what's good for the patients. It's not about what's good for the communities. It's purely union busting, putting profit over patients. And it's time that we have a law that will tell them this cannot happen. We need to have the minimum safe staffing ratios across the country.
I would say that any hospital that's willing to go public $102 million on replacement nurses while their nursing staff is walking a picket line should be ashamed of themselves. Do they think this is a good look for the hospital? And I think it's a horrible look for the hospital, and it shows what hospitals are willing to spend their profits on. But I also think this is a test case in New Jersey. And I think every hospital system is backing Barnabas in their actions right now because they are terrified. They know nurses aren't going to take this anymore. They know this. And they see that these nurses, that all of you are not willing to stand for the status quo, that you want to see real change. And I would pose this: if we had safe staffing laws, we wouldn't have nurses out on strike.
The evidence, the purpose of this hearing is not, as some of our critics think, for me to get involved in labor management relations. It's to deal with the issue that we've been talking about. Staffing ratios so that we retain our nurses. That's what this is about. And if nurses feel overworked, you correct me if I'm wrong, because of understaffing, there is demoralization, and people are leaving the profession. So we have the insane situation, and I want people to jump in and criticize me, disagree with me or not. But we have a nursing crisis. We desperately need more nurses, and nurses are walking out the door. So at the end of the day, when you have nurses who have the time to take care of their patients, who feel good about their jobs, who are not going to leave the profession, at the end of the day, benefits the hospital, the nurses, the patients. All right, maybe I'm going to go to Dr. Pitman again for this issue. We're here to talk about retention. We're here to talk about a nursing crisis where hospitals don't have the nursing they need and nurses are walking out the door. What will all of this do to make sure that we retain nurses, that we have good nurse-patient ratios? What impact will that have?
Well, as I said before, I think it is it's an essential first step, and it's also important to recognize that there's more work to be done, even if you were to attain it, because there are issues around trust in management, issues around violence and harassment of nurses, issues around employee voice that also have to be addressed in conjunction. But I think that it's really difficult in the case of nursing to do anything until you resolve the issue of the short staffing. And I think one of the things that I think would be really important, and the reason that it's so important to understand the relationship between staffing and patient safety, is that consumers should be, the general population should be very concerned about this problem. And physicians should be very concerned about this problem. And so the organizations that express the voice of those, in particular those two sectors, but others as well, really do need to, bridges need to be constructed with them so they understand the implications for them. In particular, I think for this hospital that's been with so much labor distress now, it's really important to track the patient safety outcomes. See what's happening with the agency nurses and the outcomes.
Let me ask you this, I've got a hard time dealing with this one. I get involved as chairman of the committee, and based on what I do, with a lot of labor issues, and we've been involved in many strikes, and most of the issues are pretty clear-cut. You have large multinational corporations, they want to make zillions in profits, they want to pay their workers as little as possible. Workers are standing up, we're seeing that in the UAW Teamsters. All of that's pretty understandable. Companies want more profits, workers want more money. I understand that. This is different. What's different about this is the function of a hospital is not to make you something money. The function of a hospital, I assume, every American assumes, is to provide the best quality care it can to its patients, right? So I want you to help me on this one, because you've been sitting down and negotiating with the company, with the management. What is the management's explanation when you have 1,700 nurses, people who work with patients every single day, who are fighting primarily in order to do a better job, to provide better care for their patients, which is presumably what the goal of the hospital is. All right? What is that their response? We think you, who do all the work every day, don't know what's going on the floor? Is that the response? Help me out here, because I really don't get it. If you're General Motors, if you're Stellantis, I get it. They want more money for their shareholders. I get that. But this one, I don't get. What is their explanation as to why they don't want better quality care for their patients?
Like I said earlier, it's profit over patients. Look at the CEOs. Look at how much money they make. When we come in, when we work short, the hospital still benefits on our backs as nurses, because they charge the same amount for patients, if not more. So therefore, if they could continue to use us with less in order to make more money, they will continue to do it. That is the reason we're here today testifying, asking asking to have that minimum staffing across this country, to have health equity for our communities, to continue to provide safe patient care.
What does the management say in response?
I was remaining silent for a reason. I was pretending I was the hospital at the table.
The top of our HR to get over our COVID hangover. Manny Gonzalez. He was not where we were. So these people who are hiding, can't look us in the eyes. They have. It's shameful.
We have covered a lot of ground. Are there any questions that I should have asked you that I did not ask you? Dr. Pitman?
I do think it would be interesting to think about a GAO report on the effects of the way we pay hospitals for nurse labor and support staff and labor. I think that is the root of their behavior, and the federal government bears some responsibility for that. I'm not in any way saying that this is an either or. I think that the laws are imperative to create a minimum threshold. But if we want we want to encourage them to do the right thing, we need to use the dollars, taxpayer dollars, that we pay them to rethink how we're paying them. And I think there are lots of creative ideas and lots been written about that, and it would be worth a report.
I have an idea too. We understood that the federal government and the state government gave Robert Wood Johnson an enormous amount of money during COVID, which never trickled down. I understand it was a broad base of what it could be used for. It was never used for the workers. Never used for the workers. Robert Wood Johnson. What I want to know is, where is all this money going, and who has the power to say, show us where this money is going? They took our health care benefits away. They're self-insured. What was the purpose of that except for being cruel? Their tactics are terrible, and it doesn't show any kind of concern for humans. So what kind of place is making policies, making decisions that doesn't care about the fundamental basic rights of the humans?
Let me just say this, that I would, just for the record, mention that to the best of my knowledge, this is a hospital system, Barnabas, that received $833 million from the federal government. This is a hospital that has received $3.5 billion in revenue alone from Medicare and Medicaid. So yes, federal government has played a big role. Other questions that I did not ask? All right, let me just say this, and I say this to the management. I don't understand what you're doing. I do not understand how you can go to your community and say you want to provide high quality care to your patients, and you have the leading experts on quality care, 1,700 of them, saying you're not doing it. Tell the management, I understand that, politicians are not held in high regard, but maybe CEOs of large corporations are held in even less high regard. I would hope very much that the management of Robert Wood Johnson comes back to the table. They sit down and negotiate a reasonable contract which must include adequate patient-nurse ratios. And that instead of being at odds with their union, they work together to become a model for this country as to what a good hospital can be. And let me just conclude. Our healthcare system is broken. There are so many problems. But today we're dealing with one of the major ones. And I just, on a personal note, I want to thank the union here for their incredible courage. You're standing up, not just for yourselves, you're standing up for your patients, and that is an incredible, noble thing to do. Thank you very much. And that is the end of our hearing, and I want to thank everybody and all of you who are here. Finally, I ask unanimous consent, which is not hard to get because I'm the only senator here, to enter into the record over 25 statements and documents from individuals and state groups related to the conversation today. This committee stands adjourned.